So the first speaker is Dr. Richard Saitz. Since we have very little time, he has a very impressive bio, but I'm going to go through some highlights. He's the chair and professor of community health services at Boston University, and he's been the director of Boston Medical Center's Clinical Addiction Research and Education Unit. He has numerous awards and publications, including a book entitled Your Attention, What Can We Learn from Failure? So let's welcome Dr. Richard Saitz. Oh, you need this. Thank you.
Chronic care management in the primary care setting at Boston Medical Center. The solution is chronic care management. Study that Beth Lynn did at RAND, the New England Journal of Medicine, and documented by physicians in medical records, get any recommended care whatsoever for it. And this works better, apparently. What I mean by any recommended care, it could have just been a referral. They told somebody, hey, you ought to go get some help. Only 10% got even something like that. Fewer than half of those people who seek treatment get any treatment at all. And then those who seek treatment, half of them, get detox only. Fewer than half of those people, those who end up going through detox, get any further treatment and complete it. So, what's the situation? The problem, most don't get care, and much of the care for this disease, which can be chronic, is acute, short-term care. There's a profound disconnect between the evidence for efficacious treatments and the treatments people actually get. Many specialty treatment settings do not offer all treatments that have evidence for efficacy. This is unlike the rest of healthcare. And from a patient's perspective, it's inexcusable. Heart disease treatments are not based on what a program chooses to offer, or primarily based on insurance or accessibility. When you have coronary artery disease and you show up at a hospital, the hospital doesn't say, we don't believe in medication. They don't say that we're going to determine the life-saving treatment you get based on your insurance. In addiction treatment, for example, we know that opioid agonists can improve survival. They can be life-saving. Yet many places that specialize in addiction treatment have no one who can prescribe medication, and they don't offer the treatment. Too many things in my hands. Many people with addiction have other mental health conditions. 3 chronic co-occurring conditions, as you can see in these overlapping triangles. They have other mental health conditions, and they have medical conditions. Each often affects the care of the other. For example, cocaine use affects diabetes control. That's one example. Another example, in our hospital, we see patients who are methadone clients at a clinic that's down the street. We reviewed records at our own institution and found that a substantial minority of the time, people didn't have methadone documented on their medication list when they were in the medical hospital, even though they were getting it just down the street. And as you probably know, methadone can affect the heart, it can affect the QT interval on the electrocardiogram, and there are other medications that do that too. And if you take 2 or 3 or 4 of those medications at the same time, that can cause a life-threatening side effect. So that's not safe. So conditions in these 3 domains, they occur in one person. But care for them usually occurs in 3 places in an uncoordinated, dangerous way. Why not care for them in one place? Here's an easier way to do this. There we go. The Institute of Medicine recognized this quality chasm and disorganization and called for improvement about 8 years ago. Now, one way to do this is to integrate care, you've heard that a lot, across conditions that commonly co-occur. Integrated care and longitudinal chronic care make perfect sense for addiction, a chronic disease with which other chronic conditions commonly co-occur. Imagine having asthma, depression, and an alcohol use disorder and being able to get care for shortness of breath, feeling blue, and for relapse to drinking all in one place by clinicians that know all of your health issues. Didn't work so well. Integration and chronic care management are such good ideas, they're the best things since sliced bread, that one might not think they need formal research studies to prove that they work. I really didn't even think so. But I think it does make sense to study them to see how much impact they could make. So what evidence is out there? Few studies have been done. The first 2 randomized trials were actually backwards integration. Now, it's backwards. Backwards isn't a bad thing in this case. It's just an ethnocentric view from physicians like me. Backwards integration means integrating medical care into addiction treatment settings, and that's what the first 2 trials were about. Mark Willenbring, who used to be at the National Institute on Alcohol Abuse and Alcoholism, found more abstinence and lower mortality in patients with an alcohol use disorder who also had liver disease when they were cared for in an alcohol clinic that took care of their alcohol problem as well as their liver disease, compared to those who had care for both of those disorders separately in their medical clinic and in the alcohol clinic separately. Connie Weisner at Kaiser in Northern California studied an addiction treatment program, and at that addiction treatment program, they integrated medical care, and she found more abstinence, less healthcare utilization, and lower cost in patients with addiction who had medical care integrated into that program, as I said, particularly in the subgroup who had substance abuse-related medical conditions. There hadn't been a study of integrating chronic care management for addiction into primary care. So with support from the National Institute on Alcohol Abuse and Alcoholism and the National Institute on Drug Abuse, we did one, published it in the Journal of the American Medical Association last September of 2013. We designed the Addiction, Health Evaluation, and Disease Management, or AHEAD clinic, in a primary care setting to deliver integrated chronic care for addiction. Patients with alcohol or drug dependence saw 4 clinicians in one place. Now, I'm going to give you a lot of detail about this. They saw a nurse care manager, a psychiatrist, an internist, and a social worker, all with addictions expertise. All clinicians were trained in motivational interviewing. They were all trained in relapse prevention counseling. All patients were offered motivational enhancement therapy, psychiatric and medical care, concrete social services, all of those things based on the patient's priorities. The main focus was to engage them in care and provide any and all known effective treatments based on their specific conditions when they were ready to take them. There's more. These included psychosocial treatments and medications for alcohol and opioid disorders. All of them got a primary care physician, too, in the same clinic. Protocols and experts provided decision support to assure high-quality care. We referred people to addiction specialty treatment programs with warm handoffs and recommended 12-step programs. We facilitated psychiatric and medical specialty referrals as needed. There's still more. We used does this sound like your clinic? We used information systems to track people, and the nurse care manager proactively called people who didn't come in for appointments. Drop-in care was available. 24-hour pager access was available. People could return even if they were intoxicated or using drugs, and we let them know that they were welcome. This, I think, is the Cadillac model. We randomly assigned people to all of that. We randomly assigned people to get all of that, or in the control group, we gave people a primary care appointment, and we allowed them to fend for themselves in the healthcare world. So what did we find in this comparison? A friend and colleague who's a prominent addiction psychiatrist told me, quote, It wasn't the most colossal failure. That was Harold Pincus at Columbia. He was letting me down easily, I think. But it was pretty bad. We were disappointed. Now, although we found a tiny, tiny benefit for reducing alcohol problems among those with alcohol disorders, we found no differences 3, 6, or 12 months later in abstinence, biological measures of drug use, biological measures of heavy alcohol use, addiction severity, mental health-related quality of life, physical health-related quality of life, hospitalizations, or emergency department utilization. If it's such a good idea, why didn't we find any benefit? Well, we're not alone. In a recent study of chronic care management for chronic obstructive lung disease, the intervention increased mortality. In a recent study of a place where integrated care is the goal, the patient-centered medical home, little benefit was found. Why not? Why not? Well, one size doesn't fit all. Integrated care, the mantra of the day, chronic care management, is not a magic bullet. It won't solve all problems. Why not? It should. Well, substance use disorders are not one thing. A single solution doesn't fix a complex problem. We wouldn't talk about chronic care for heart disease. We wouldn't. We'd talk about specific types of heart disease, like heart failure with a specific ejection fraction, or coronary artery disease with a certain number of arteries that are blocked to a certain extent. These diseases, when so specified, have specific treatments that when they're organized, so when you organize specific treatments for specific diseases that are known to be effective, then organizing and integrating that care can be very effective. So we, in that study, approached substance use disorders as if they were one thing. And I think that they'll be found to be more complex, and we'll be able to characterize them better than we are currently able to. And then we'll get more individualized treatments. And then we'll see that integrated care can have a dramatic effect. Now, organizing care can only work if the care that's being organized has efficacy. We know some treatments work for addiction, but not all of them. And some that work have modest efficacy, and even those that have modest efficacy may not be offered to all patients. They may not be offered to all patients consistently. And most proof the treatment works comes from studies of people who are seeking help. Yet most people with these conditions aren't seeking help. Integrated chronic care won't help them. There have been some very recent promising examples. In a randomized trial in Pennsylvania, integrated care worked for veterans with alcohol disorders who were ready to accept referrals for treatment. They got medical treatment, naltrexone, and counseling in a primary care setting, or separately, where they got their medical care from primary care and then their naltrexone and their counseling in a specialty treatment program. The integrated care group in primary care did better. Now, in that trial, a couple of distinct features compared to ours. People were ready enough to change. They had agreed to treatment. And that wasn't necessarily the case in our study, in which we took all comers. So for those veterans, chronic care management and integrated care worked. She says, "I've heard the saying, but I never thought it was something that could actually happen." We shouldn't throw the baby out with the bathwater, and I don't mean to do that. I cannot accept that integrated care is not better than separate, disorganized, uncoordinated care. I have a patient with opioid addiction who I treated with Subutex during her pregnancy, who also came to me to have her asthma or shortness of breath managed, and whose anxiety symptoms I also managed, all in the same place, with the same team, and the same visit. That has to be a good thing. It just has to. It's more convenient, it's safer, it's more effective, it's better. But just like other health conditions, the details matter. What we learned from failure is that integrated chronic care management might not work for all. It might not work if we just apply it willy-nilly everywhere. That's important to know because it's hard to do. It's hard to do and it costs a lot. It'll likely work for people for who? For people who are ready for treatment, and for those for whom there are known, effective, and available treatments, like, as an example, medications, opioid agonists for opioid disorders, medications for alcohol disorders, psychosocial treatments that are manualized, that have been proven to be effective. Redesign of the health system to deliver integrated care can't fix a lack of widely available effective treatments. We need to avoid implementing it everywhere, thinking that we're going to solve all problems with addiction care. We risk saying, aha, integrated care, we've done it, problem solved. We can't stop looking for more effective treatments, delivering the highest quality of care we can now, and getting people to want that care and helping them access it. I really do remain optimistic that chronic care management for addiction will work. It will have its place. But we also know that we can't assume that we've solved the problem with this latest bandwagon of integrated chronic care management. What can we learn from failure? I think a lot. Thanks very much for your time.
See, now that's a great TED Talk. Why? Because when you saw that F, didn't you say, oh my God? Yeah. And that's exactly it, of just challenging some of our sort of existing beliefs, things that we've come to accept, and really stretching our thinking. We're also going to now hear from Dr. Brenner, who will also help us stretch our thinking, and share ideas that are really worth spreading.
Thank you very much. I appreciate the chance to be here. So I'm a family doctor, primary care doctor also, from one of America's poorest cities. I work in Camden, New Jersey. So I want to start out by telling you a little bit about Camden, New Jersey and about what I do there. And my goal today is share a little bit about what primary care can learn from behavioral health. So I have 3 stories to make that point and 3 points to make. So Camden, New Jersey is 9 square miles. It's right across from Philadelphia. It's the first, second, or third poorest city in the country and the first, second, or third most dangerous city in the country. We have been in state takeover for many, many years. We can't afford our own bills, so the majority of our budget's paid for by the state government. Our school district, police department, city government have all been in oversight. Our police department, we've tried many, many different things to fix the police department, and our most brilliant recent innovation was to actually lay off half of the police department. And in case you're wondering what happens in the most dangerous city in the country if you lay off the police department, the second most dangerous city in the country, it becomes the most dangerous city in the country. So it doesn't work very well. And at that point, we decided that was so successful, we'll actually lay them all off. So we laid off our entire police department, closed it, disincorporated it, and we moved to a county metro department, which is actually beginning to work, and we're beginning to tamp down some of the crime rate. So when I graduated from medical school and graduated from residency, I wanted to practice in a poor, underserved community and had grown up near Camden and got my dream job there. And it was a job in a 3-exam room office taking care of a Latino underserved community. So I got to spend most of my days running from room to room to room, speaking in Spanish, and also delivering babies. So I had learned in Seattle how, as a family doc, to deliver babies. So I'm seeing kids, adults, and delivering babies in Camden. And really, in some sense, I was a refugee from the American healthcare system. I wanted to be as far away from everything I'd seen my mentors do, and as far away from everything I'd seen the American healthcare system do to people. And there's probably no better place in America to hide than the poor city in the country, in a small 3-exam room office as a primary care doc. It was really a wonderful place to be. And my patients taught me a lot there, and I want to tell you the story of one of my patients that I met there, and it was in my first year. And in my residency, I had a chance to learn a fair amount of behavioral health, I thought. I did joint appointments with a psychologist, I did joint appointments with a psychiatrist. That's a lot of exposure as a as a young person, 25, 26, 27. So obviously my patients had lots of mental health issues practicing in Camden. And I had a patient come in and see me one day, and I just want to read a very brief passage describing her coming in. The foul smell of her gangrenous toe filled the room like 1,000 shrill voices pointed at me, her young family physician, all saying the same thing. You don't know what you're doing. The pus coming from the open sore was like a test I could never pass. Its putrid smell, the inescapable evidence of my incompetence. I had finally found a standardized test I couldn't conquer, no matter how hard I tried. With sugars in the 500s, 600s, she terrified me. I sent her once directly to the emergency room, overwhelmed and embarrassed. I was sure my colleagues in the hospital would assume I was just a stupid family physician, not smart enough to become a specialist like them, relegated to being a family doc in a ghetto 3-exam room office because I couldn't do any better. And maybe they were right. I opened my books, I went to conferences, I would call specialists on the phone and try and get them to help me with the cases, and I struggled with each patient, and particularly struggled with this patient. For some reason, she kept coming back, and every time she came back, there was another missing part of her foot, another missing toe. And as someone who was very good at passing tests, she was the test I just simply couldn't pass. And we're taught to do many, many different things when a diabetic comes into our office, all sorts of questions. Tell me about your diet, tell me about your exercise, are you taking your medicines? And I was so certain that she was cheating right before she came in to see me. Surely she was drinking juice just to spite me, and not taking any of her medicines. And I was really mystified by why she would keep coming back and seeing me. I finally just got, as you see a patient like this, if you can imagine what my office is like, the waiting room is overflowing. There's kids crying in the waiting room. The office is so old that you can barely fit a wheelchair down through the office. It's overflowing with patients, and you're backed up, and you're always late. You always feel like you're running from room to room to room and never quite getting anything done. You stay at night till 7:30, 8 o'clock. You have piles of labs, of radiology results, of refills to do for people. And at the end of the night, you just go home exhausted. So you get angry at a patient like this. And as her toes got shorter and I looked at her with sort of a just veiled contempt by what she was doing to me, she looked back at me with sort of veiled contempt of what I wasn't doing for her. And finally, I set the chart down and I said, who in the world is this person? She had as many older patients in Camden have a sort of a vague Southern accent, and asked her, so how did you get to Camden? I mean, where did you come from? So it turned out that she'd come from South Carolina, and she had moved to Camden almost 50 years ago when it was a much, much nicer place. And in her first year in Camden, her fiance and husband at that point had died. And she was just stuck in Camden. And I want to read for you just another little passage about her. She was stranded in her grief, stranded in the poorest city in the country, stranded for over 50 years in a way that happens sometimes with a broken heart still waiting to heal. She was stranded in my office on my exam table, giving me a test I couldn't pass, losing toes by one as proof of her love long lost. When I learned that she was a retired kindergarten teacher, I couldn't breathe. It seemed irreconcilable to me that a kindergarten teacher could do this to me, give me a test I couldn't pass, or do this to herself. Somehow in my mind, there was nothing more powerful, all-knowing, all-seeing than a kindergarten teacher. They were filled with virtue, wisdom, and compassion, not people with gangrenous toes torturing incompetent ghetto family docs. So as the days went by and we got to know each other better and better, she actually began to open up and tell me more of her story. And she never became a model patient. Her sugars went down slightly. She began to take some of her medicines. She would never let me really treat her for depression, but somehow just coming into the office really was moving her in the right direction. And that story taught me the power of the hidden narrative and the degree to which, as a 28-year-old, I couldn't imagine the kinds of things that happen in people's lives and the trajectories that they go on and how they end up in our offices. and how ill-equipped I was at that young age to even begin to grapple with what was going on. You know, I was really a young apprentice, and what she needed was a master craftsman, and that's not what I was at the time. And I've learned, you know, since then that, you know, when I'm in a meeting, when I'm in a room like this, I'm not here just with you. I'm here with your family, with your siblings, with your cousins, with your neighbors, with anyone who's ever affected you. And she has taught me so much in meetings I attend and in the work I try to do. Just, you know, we're in a web of connections of many, many different people who some have left scars, and they're in the encounter with us. So I want to share two other stories. One was as I did more and more deliveries in Camden, I would take calls from my own patients. So they would call any time in the middle of the night, and I'd stop doing what I do and answer the phone. And I did my own deliveries. So I'd go running out any hour of the night to go and deliver patients. And I did that for about 10 years. And I also lived in the city of Camden. So my young fiance at the time and later wife moved to Camden with me, and we lived there for about 8 years. She got pregnant with our first child, and we stayed there, got pregnant with our second child. And my practice was just getting busier and busier. It was a private practice, so I had to pay my own bills as well. And during the birth of our second child, about a day later, I left our house when I should have been off for my 2-week paternity leave and went back to do another delivery with a patient. And I came home, and she was so mad at me that I'd left, and I couldn't imagine why she was mad at me. And I was just doing my job. And somehow in my practice, the work of taking care of poor women, patient after patient after patient, I had really lost sight of my own family, and I'd lost sight of my own, you know, what was going on in my own life at the time. And at one point I said to her, you know, at least you have a roof over your head. You know, at least you have food to eat. At least you have a husband with a job. You know, and I had begun to measure my own wife and my own marriage with the yardstick of what was going on in my practice and just how crazy that was at the time. And that really taught me that it's pretty easy to lose perspective in this work, and it's really easy to not take care of yourself and even not take care of your own loved ones. And the last story I want to tell you about my practice is I just forgot the last story I want to tell you about my practice. So let me wrap up by saying there are really 3 lessons that I learned from the practice. One is the power of the hidden narrative, as I mentioned already, that there are so many narratives that my patients walked around with, and how really poorly trained I was to really pull those narratives out, and how little I understood those narratives. The second is the power of stress and trauma. I think that the real revolution of connecting the mind and the body is going to come from the stress hypothesis. As a physician, I couldn't connect with behavioral health until I really both experienced it for myself and my family, but also began to understand the mechanisms of how all this stuff works. You know, as a young clinician and a scientist, I could get my head around the idea that the pituitary thalamic axis is the mediator of stress, that there's a chemical called cortisone that courses through your veins and causes your body to respond to stress, that what's an adaptive coping mechanism can become a maladaptive coping mechanism. I could begin to understand that. I could see it happening amongst my patients. So the third story in my practice in relating this was in my 3rd or 4th week in practice, I thought I had discovered a rare outbreak of a rare disease in Camden. And as a young clinician, you sort of feel like you're Sherlock Holmes, like you're going to find something that no one else has ever found. So I had one Latino woman after another in this little neighborhood come in with a buffalo hump. They were sort of crouched over like this, and they had a big fat pad on the back of their neck, and they had a round face, and they all had stretch marks on their abdomen. They had spindly legs, they had weak muscles, they couldn't sleep at night, they couldn't keep memories, they couldn't form memories very well, they had lots and lots of depression, they were all mildly diabetic. And if I give all of you a pill called cortisol, a steroid every day, you would all look like that at the end of a couple of years. And there's actually a disease where you can have a tumor that produces cortisol called Cushing's disease. And I thought in Camden that I had discovered a rare outbreak of Cushing's disease in a neighborhood. And there's a very difficult test to do where you collect people's urine. They pee all night in a jug. and then they bring it into your office and you test it. So I tested one patient after another. I was sure that I'd found an outbreak of Cushing's disease in Camden. And what it turned out to be is a city full of really, really stressed out people. And that living in Camden was like taking 5 milligrams of prednisone every day, that it would begin to destroy your body. And for me, that's what connected me to the mind and the body, that I began to understand the incredible power of stress on people, the power of stress in my own life, and what I was seeing in my practice as well. So what behavioral health can teach primary care is at some point, primary care providers will be ready to listen to what you have to teach. And it may take a failure in their own life, it may take the stress of their own practice, but at some point they're going to be ready. And really the power of self-awareness is probably the most important thing you can teach them. Primary care docs have very high rates of marriage failure. They're very unhappy right now about the hand that life has dealt them and the work they have in their practices. Many of them may come at some point to seek help from all of you, and probably the most important thing you can teach primary care is the gift that you have to give them, which is a gift of self-awareness. So thank you very much.
I need a clicker for you got the clicker?
I'll get you the clicker.
Well, actually, it's great to be here, and it's terrific to follow Jeff, because the story I want to tell is very much related to the story he told. It's very much about prevention and the state of our science. It actually builds nicely, I think, on Tom Insel's talk as well. I would disagree a little bit in terms I think we actually know a lot of stuff that we don't do. What I found in trying to explain this to people, so this notion of prevention, it's very helpful to think about the 1880s and when we were having terrible cholera epidemics, right? In the 1880s, 100,000 people in London died from cholera. And at the time, we thought that was caused by miasmas, by bad air. People didn't know what was actually causing it. But through careful epidemiological work done actually by an epidemiologist named John Snow, he determined that it was actually something going on in the water that was making people. He wasn't sure what it was, but he knew if he took the pump handle off the Broad Street pump, he predicted that cholera would dramatically reduce, and it did. It wasn't until 30 years later that Pasteur and Cook identified the cholera bacillus and started to understand what we needed to do to effectively treat infectious disease. The public hygiene movement that came from that revolutionized everything. Nothing has had a more profound effect on our health than public hygiene, cleaning up the water, making our food safe. And I want you to imagine, take yourself back to that time and think about saying, okay, well, we understand now there's something in the water, and it's something with human waste contaminating the water that seems to be making people sick. So how are we going to fix that? Well, let's do this. Let's take clean water and a pipe system and put a pipe into everyone's house so that everyone can have clean water, right? And you know what else we should do while we're doing that is let's put another pipe in every one of those houses and let's move all that sewage out and don't dump it out into the street the way we're doing, but actually treat it. Can you imagine how likely you think that what people would say, you're out of your mind. You think we're going to be able to put a pipe into everybody's house and another pipe coming out? But we had a theory. We had a strong theory. We had strong community involvement in trying to understand and deal with these issues, and we did it, right? And now we take that whole public hygiene movement pretty much completely for granted. Now, my hypothesis for you today is that our contemporary epidemics, and this relates very much to what Bruce was just talking about, our contemporary epidemics are all behavioral. And I basically want to make 3 points today. The first point is we're in a hell of a mess. And I'm going to document that for you in lots of different ways. The second point is the good news, and that we know an awful lot about what we can do to start to change these situations. But it's going to sound to you as though I'm saying, look, all you need to do is put a pipe into everybody's house, right, and another pipe coming out. At the time, that had to seem unbelievable. But we actually have very strong prevention science that guides us in terms of the principles and programs that make a big difference. And our job as behavioral health experts is to deal with these behavioral health epidemics by implementing the science that we have now. And as Tom was talking about it in terms of his remarks in the plenary, that science is going to get better. We're going to understand more granularly what's actually going on in terms of that neural wiring. But just like John Snow removed the pump handle and stopped the cholera epidemic, we are in a position to do the same thing as we continue to discover, as Pasteur and Cook later did, the specific elements that were causing those problems. So we're in a mess, a hell of a mess. Global life expectancy in this country, 20 years ago, we were 11th in the world. We're currently 50th in the world in terms of global life expectancy. I think everybody here knows, since we work in the healthcare business, that we have those terrible healthcare outcomes in the context of spending twice as much as every other industrialized nation per capita on medical care. We have the highest rates of mental illness in the world. The lifetime rate of mental illness in the United States, according to the National Comorbidity Study, is about 50%. 1 in 2 of us will meet criteria for a diagnosis at some time in our life. Mexico, the rate's about 25%. It's half of our rate. When people move from Mexico to the United States, their rate of mental illness is about 25%, the same as the rate in Mexico. 13 years later, their rate has increased to 50%. We're in a hell of a mess. We have 44 million people living in poverty in this country. We have some of the highest income inequality, which turns out that the distinction between the very rich and the very poor is probably more important than the absolute level of poverty in terms of its adverse effects on people's health. We have shown substantial decrease in terms of our academic ability. We're dropping in terms of the OECD nations, in terms of our mathematical literacy, in terms of our science literacy. We're in a hell of a mess. The costs of mental illnesses, social, emotional, behavioral disorders in kids, the IOM estimates to be about $247 billion in 2009. We inflated that forward. It's over $300 billion. It's about the same for people who have severe mental illness in terms of their loss of human capital. That's the equivalent to losing a Fortune 5 company each year, right? Only Exxon and Walmart had gross revenues over that amount of money. That's how much money we're losing from productivity in our system because of these behavioral health epidemics. So how did we get here? Well, we actually have a pretty good emerging general theory, and this again relates very much to what Bruce was just talking about. You know, we know now, when I was an undergraduate way back in the Pliocene era, there was a lot of argument about whether or not there was any real genetic basis to mental illnesses. We now know from many, many, many studies that there's a heritable component of mental illnesses, but we also know, just like many other conditions, that gives you a sense of your risk profile, but biology is not destiny, right? So we know that if people who have certain vulnerabilities are placed in environments where they're traumatized or where they experience toxic stress, that increases dramatically the likelihood that they'll become ill. Now, pretty much everybody here familiar with the Adverse Childhood Experiences study, the ACE study, which is good because many, many audiences are not. It's amazing to me, still aren't familiar with that study. But basically what that showed is people who experienced adverse childhood experiences, particularly 4 or more, had much worse behavioral health outcomes. They were much more likely to be addicted, much more likely to be depressed, but they also had much higher rates of infectious illness and cardiovascular illness, et cetera, et cetera. So this very much relates to what what Jeff was just talking about. So it's vulnerability coupled with environmental exposure, and here we're talking about toxic stress and trauma. And Jeff was talking about the fact that we now know, the more I look into this, the more surprised I am about how well developed and extensive a literature is available, that this results in rewiring of our brains. It affects cognitive functioning, it affects executive functioning, it affects emotional regulation. There's some work that was done by Gary Evans that showed people who were in toxic stress situations had dramatically depressed levels of cognitive functioning across a broad amount, like 3 standard deviation differences from people who hadn't experienced that. And that is, for any of you who, I don't want to traumatize you by reminding you about statistics, but for any of you who remember how big a standard deviation is, 3 standard deviation is a gargantuan effect. So that leads to behavioral health problems, right? This is speaking beyond our data currently, but someday we're going to understand that the sentinel conditions, and this fits very nicely with, I think, what Tom was talking about in his talk, the sentinel conditions for many, many chronic health conditions are, in fact, the behavioral health conditions. They are the things that show up first, right? We used to think that mental illnesses and addiction disorders were disorders of young adulthood. We now know that they're disorders of adolescence, early adolescence, right? That half of everyone who's going to have a diagnosis during the course of their life will have that diagnosis by age 14, right? Like Tom said, 3/4 by age 25. What else do we know? Another sad fact is, on average, those people will not get any treatment for 10 years. As they move through adolescence, through this important life launching, you have to get through high school, get some sort of post-secondary education, and we've known this for a long time. So what happens? Because of this relationship between vulnerability and stress starts to rewire the brain, depresses various kinds of cognitive and emotional functioning, academic achievement starts to drop, right? Some of the strongest predictors of people not completing high school are people who have social, emotional, behavioral disorders. So as academic achievement drops, what happens? Occupational achievement starts to drop, right? We see, particularly as we've been focusing recently on the unemployment rates and the unemployment rates amongst different groups of people, we've clearly seen that people who have less education have higher unemployment rates, and they're working at much less lucrative positions typically, right? So as socioeconomic status drops through compromised academic achievement, people live in poor situations, in more toxic situations, and so we have a perfect storm, right? Such that you start with vulnerability, you add stress, causes brain damage of one sort or another, behavioral health problems, academic problems, occupational problems, poverty, which puts you at higher risk for stress, and that's how you start to get these multi-generational problems. And we have good data to understand that there are critical periods, particularly in prenatal development, early childhood development, where it's essential that we do things to try to ameliorate these stress. Now the good news is we know a lot of things that work, that make a big difference. We actually have very strong longitudinal data on the effects of some interventions. The nurse-family partnership is one I think that's well understood. And even though those original studies were done over 30 years ago, it's finally getting rolled out around the country, right? This is where a nurse who's trained in the program visits young, poor moms for their first pregnancy and works with them for a period of 2 years. If we do that, we know that we decrease child abuse rates, right? One thing we want to do is we want to drive down trauma. We decrease child abuse rates by 48%. We increase the social emotional behavior of the children themselves. We decrease the rates at which the mothers get arrested, the rates at which they use Medicaid services. So there's good indication that that attacks many of these problems we're talking about in terms of our general theory. The Seattle Social Development Project is a project that works with kids, teachers, and parents, skill-based, skill-oriented, training parents to be a bit more effective, encouraging kids to take chances, and giving them feedback about how they're doing. This study, this is a randomized study. The Nurse-Family Partnership was also, I mean, these are absolutely first-rate, rigorous studies. The Seattle Social Development Project was grades 1st through 6, kids receiving treatment. This is 15-year follow-up data, right? Nothing systematic has happened to these kids over that 15-year data. And what you can see that through this graph, and I wasn't supposed to use very many graphs. So you please tolerate this one graph. What you can see is that by age 27, 15 years after the end of that intervention, there's a 38% reduction in diagnosable mental illness. That's why I think of these things, and this is where I would disagree with Tom a little bit. I think we have some behavioral vaccines. They're not 100% effective, but that's a pretty dramatic effect with no intermediate services being delivered. The good behavior game, and I thought that Justin Bieber was a perfectly appropriate person to talk about here, is a game that's played by first graders. It's actually getting a fair amount of press recently. It's very behavioristically oriented. You reinforce good behavior. You try to ignore bad behavior. You have kids work in teams, and they get prizes. First grade intervention. If you look at kids who had that intervention 13 years later, they're 21% more likely to have graduated from high school. They're 61% more likely to have attended college. They're dramatically reduced rates of alcohol abuse. These are like behavioral vaccines. There's no excuse, from my perspective, for every child in the United States not having access to one of these evidence-based practices. And you know what else? It's good for the economy, right? Because we're building human capital. There's a great organization in Washington called the Washington State Institute for Public Policy that was created by the legislature there, and their task is to estimate the cost and benefit of various types of programs. So they describe themselves as the portfolio managers for the state legislature. They make recommendations about where the state legislature should invest its money, and so they do a lot of cost-benefit analysis. So they estimate that an early childhood education program, for every dollar you spend, you get back $2.36. That nurse-family partnership, for every dollar you spend, you get back about $2.88. The social development project returns about $3.10. And the Great and Good Choices program is a much less expensive program, and for it you actually get $11 back for every dollar you invest. These are smart investments. And you know what? They're part of the legacy of the community mental health movement. Some people I can tell in the audience are from my generation, like I said, back in the Pleistocene era, and you'll recall back then that there was a very high vision for what community mental health was going to achieve. It was a lot more than I think what we have come to focus on in many, many states, which is really focusing on people with the most severe illnesses. And it's not that that's inappropriate at all, but I think it's time for us to start to reclaim what was our original vision. And I think that one of the things that distinguishes now from then is we now have science-based approaches to achieve many of the sort of ideologically inspired vision of the original community mental health movement, based on very well understood behavioral theory. And as you can see, in terms of sort of this theme of integration, very nicely integrated between biology and behavior, starting to break down this meaningless distinction between mind and body. So how do we get there from here? Well, we have to do basically the same exact things that we had to do in public health, right? So you see up there a little baby getting a vaccination, right? We have to make sure that we can implement those behavioral vaccines that we were talking about. And we actually have a fair amount of money that we spend in this country on various kinds of prevention interventions, not well coordinated, not well strategically managed. We need to do a better job there in making sure that every child has access to those programs. Every child, every mom and child has access to a healthy pregnancy. It's in our enlightened self-interest to do it. The malaria nets that we're trying to get distributed around the world, you know, the insecticide nets that keep people from getting exposed to malaria. We need things like that to help buffer the effects of toxic stress. Things like income support programs, housing support programs for poor people, ultimately giving everybody kind of a fair shot to make a difference in terms of their life. So we need things that reduce community risk factors, family leave policies, and Jeff was just talking about his experience with a new baby. Family leave policies that support people so that moms and dads have an appropriate opportunity to attach to their children, which we know now, again, from lots and lots of research is critically important. The person getting the injection really talks about treatment, right? Jeff and others talked about the effects of trauma, and we talked now a lot about trauma-informed care. One of our legacies, an unfortunate legacy I think in our field, is a tension between prevention and treatment, right? Particularly from a preventionist perspective, because they think that damn treatment gets all the money, it always gets all the money all the time. We have to now realize that with this new integrated theory, it would be like saying, well, what do you want to give up? You know, vaccinations, which would be prevention, or antibiotics, which would be treatment? You say, well, that's a silly question. You know, we need both vaccinations and antibiotics. In this area, we need both effective treatment for people as well as preventive interventions for them. So this is the call to action here and now. And we're a group that needs to be a stand for these kinds of problems. We've got the data. We have in our ideological DNA from the development of the community mental health centers movement a vision of community health, well-being, equitable opportunity, and we now have the science base that we know we can use to implement that vision. So number one, we need to integrate prevention and treatment. We need to get rid of this distinction between the two and realize, just like vaccinations and antibiotics, that if we're going to make the difference we want to make, we've got to have both preventive and treatment interventions. This notion about rediscovering community mental health, going back to our roots in a sense, but with a much more powerful science base than we had in the past. We need to lead the next movement in community well-being and productivity. I really see this as our legacy. You know, to the degree to which that model is right, and again, Jeff's talk was a perfect lead-in for this. We now have the theory. We've got the amount of information we have is more than John Snow had when he removed that pump handle. We've done that careful work. It's time for us to implement that program. We need to generate political will. You know, Julius Richmond, who's a giant in terms of public health, he was an assistant secretary of health. He started in Johnson administration. He was part of the war on poverty, started the Head Start program, said that you need three things to really make a difference. You need science, and we've got good science. We're going to get more. We're going to understand more about how all those networks are put together, et cetera, but we have got actionable science right now. You need to know how to implement it. And we're continuing to work on that. That's a challenge. This is the thing I think that Rich was talking about in terms of the quality of implementation, and he talked about the study, the RAND study that showed how poor across healthcare in general practices are relative to standards, and you need political will. So we need to be a stand for that. We need to be the people who say, look, we can in fact put a pipe into everyone's house to bring in clean water, and another pipe coming out of that house to remove waste safely so we don't infect ourselves. We need to think about it in terms of reducing economic inequality, promoting social programs that reduce toxic stress, making sure that every kid has access to an evidence-based prevention intervention program, making sure that every mom and family, I'm thinking principally of the prenatal period here, so dads are known to be part of this process as well. Every mom have access to prenatal care, adequate nutrition, et cetera. We know what to do. It's a matter of marshaling the political will to get it done. We can't afford not to do it. It's in our enlightened self-interest to do it. And this is the group, I think, that needs to lead the next revolution in public health, which will be approaching and attacking these behavioral health problems. Thank you.
I want to thank our distinguished speakers. Please join me in applauding their excellent talks today. We also have another series of TED Talks at 3 o'clock today, and then tomorrow, as well. Good idea, these TED Talk formats? Like it? Great. We'll continue doing it. Thanks so much.